Today I'd like to walk you through my experience utilizing a new tool that we have in nephrology, which is the Renal gene panel. So we'll start with case one. This is a 28-year-old white gentleman who presented for a second opinion evaluation of nephrotic range proteinuria. So his story actually started when he was at age 10, so quite a few years before he saw me. He did not recall the specifics. He was quite young at the time, and he remembers his mom taking him to the doctor and ultimately having a kidney biopsy done. But he stated that he did not recall receiving a specific diagnosis or any specific treatment. Ultimately, we were able to track down his kidney biopsy from the pediatric hospital and saw the results were that it demonstrated mild mesangial hypercellularity with global glomerulosclerosis. The immunofluorescence staining was weakly positive for IgA and slightly more strongly positive for C1q, but no definitive diagnosis was really suggested outside of possible C1q nephropathy, and no specific therapy was initiated. Over the subsequent 15 years, he remained asymptomatic. He had no other exposures, no drug use, no HIV exposure, and he had no family history of any kidney disease. He was reevaluated as part of a routine physical, and he was noted to have persistent proteinuria. He was referred to a nephrologist, and his proteinuria is quantified at 2.5 gram per gram creatinine on a random urine protein to creatinine ratio. Ultimately, he underwent a repeat biopsy approximately 3 years prior to seeing me. And at that time, his biopsy revealed focal and segmental glomerulosclerosis. There was negative immunofluorescence at this time, and his podocyte foot prosopagement was characterized as moderate. Although he didn't have overt symptoms of nephrotic syndrome, including edema or hyperalbuminemia that was severe, given his age and demographic, there was a concern for a primary FSGS, and he was initiated on high-dose prednisone, 60 milligrams daily for 3 months, as is the standard of care. Despite the prednisone, his proteinuria did not change, but his renal function had remained preserved throughout this entire course with a creatinine of 1 milligram per deciliter. Further characterized as steroid-resistant FSGS, he was initiated on second-line therapy or subsequent therapy with highly purified ACTH gel or Acthar for a 12-month course. Once again, he had no response with regard to his proteinuria, and his renal function remained preserved. At this point, he was evaluated for additional evaluation and further investigation in terms of what would be the next best course. So at the time of my evaluation, he had no edema, his albumin remained normal, his blood pressure was controlled on 40 milligrams of lisinopril daily. He still had nephrotic range proteinuria. However, given his sort of atypical FSGS course, the fact that his renal function remained preserved and he hadn't had overt nephrotic syndrome, as well as the already demonstrated steroid resistance, he decided to defer additional immunosuppressive therapy at that time. So I'd like to take a digression here and walk through a more updated proposed evaluation of FSGS. The difficulty in FSGS has always been that it is a pathologic entity rather than purely a disease process, and how to appropriately walk through first-line therapy, second-line therapy, and when we should no longer initiate immunosuppressive therapy can be a difficult decision to make. So this was a nice review published in JASN in 2018 by some of the leaders in the field, DeVries, Sanjeev Sethi, Fernando Fravenza, Richard Classic, and it walked through a more global evaluation of FSGS where the kidney biopsy was taken into consideration, including the electron microscopy, as well as the remainder of the clinical scenario, specifically the response to steroids. So if you go on all the way on the left, in one category, the nephrotic syndrome, including diffuse foot prosopagement in the setting of FSGS. And this would be certainly considered as first or primary FSGS. So first-line therapy, of course, is most of the time steroids. And their response, then you can conclude that they have a primary FSGS or immune-mediated FSGS, and then move forward with how to maintain remission. However, in almost every other category, outside of individuals that have a clear secondary cause, if they are steroid resistant or they have other features that are a bit atypical, such as nephrotic range proteinuria but no nephrotic syndrome, meaning albumin range normal or near normal and no edema, or they only have segmental for process effacement and an absence of a secondary cause. All three of those categories are subsequently referred for genetic testing under this algorithm. The problem with FSGS, as I mentioned, is that it's been always characterized as a pathologic entity which really does not appreciate the underlying pathogenesis. And so in a nice review Andy Baumbach did and AJKD from this year, they try to recategorize FSGS, or the podocytopathies more globally, based on the underlying pathogenesis. Really 4 categories. The one that we think of as primary FSGS, or immune-mediated, is in the green, the permeability factor-mediated podocytopathy. The one we conventionally consider secondary FSGS, or the hyperfiltration-mediated, is in the blue there, referred to as adaptive FSGS. The 2 other categories, which in the past have been considered as quote-unquote primary FSGS, are really more characterized, again, in terms of the underlying etiology. Either a toxic podocytopathy, such as that occurs after parvovirus B19 infection or exposure to certain medications. The last category being the genetic podocytopathies, where an individual has a known or suspected GBM gene mutation, such as mutations in type 4 collagen, nephrin, podocytin, TRPC6, etc. So this categorization provides a more etiology-based classification of FSGS, and again can help us in terms of decision-making with regard to how to move forward. So we go back to our patient. Which of these categories does he fit in? Does his clinical picture really fit with an immune-mediated injury, such as is seen in the permeability factor-mediated podocytopathy, or is it another category? And I would argue that the many atypical features is just another category. And this, of course, is critically important because if it's another category, he will not benefit from additional immunosuppressive therapy. Not only is it important from the standpoint of initial therapy, but it's also important from how we stratify his risk for long-term progression, as well as if he progresses to end-stage renal disease, will he have a recurrence? Because those with the genetic cause, of course, have essentially 0 risk of recurrence. So classifying and then moving on to try to become to a more precise definition, diagnosis even, has important implications for the patient. So genetic testing is a tool that, to be honest, we haven't had for many years, or at least routine use in clinical practice. But we have very strong implications of those results that can be critically important in terms of decision-making, as well as how the patient can frame his or her disease. And genetic testing can help distinguish between these circulating factor-mediated FSGS and those with a structural defect, such as a mutation in type 4 collagen. If you were able to identify someone has a genetic mutation that's causing FSGS, you're going to be able to reduce exposure to treatments that are unlikely to be helpful and more likely to be harmful, such as more immunosuppression. And then from a long-term standpoint, you can better prognosticate individuals for what's going to happen to their kidney function over time, as well as what to expect for them post-transplant. While we don't have any specific therapies, there are more clinical trials going on FSGS now than there ever were, and understanding the underlying etiology may help us more rationally refer individuals to clinical trials based on the mechanism of each agent. Ultimately, we'd all like to arrive at the utilization of a precision medicine-based approach, and genetic testing really takes us one step closer to that. So based on those potential implications, we counsel the patient on renal-site kidney gene panel testing, and he completed a salivary test, and he did yield a positive result. And the result yield was a mutation in type 4 collagen that is oftentimes seen in Alport syndrome. And this is a snapshot of the actual report. And you can see that it provides you with not only the mutation, but also the classification, which is likely pathogenic. And with this information, we can more accurately complete his clinical picture. Just like any other test result, though, you take a step back and say, well, does this test result fit the clinical picture? What are the implications of this test? And most importantly, how do we counsel the patient on the results of this test? So first, does this fit the clinical picture? And the answer is absolutely. We know based on a lot of data that's come out more recently is type 4 collagen mutations are really the most frequent mutation in specifically steroid-resistant FSGS. And this is a study published in 2016 out of the UK, identified, of those that were identified to have a definitive pathogenic mutation, over half of them were in type 4 collagen. So how do we utilize this information? Well, certainly based on this, we would confirm that there is no role for additional immunosuppression. This is a structural issue, not an immunologic issue, and so immunosuppression is not going to reverse this injury. However, from a long-term standpoint, he does remain at high risk for renal disease progression. He already has glomerulosclerosis. He has a known mutation that is not going to get better, and therefore we have to be prepared to counsel him on that, what that may mean. In terms of therapeutic intervention, our focus is really going to be on non-specific antiproteinuric therapy. At this time, only RAS blockade, ACEs and ARBs. But in the future, as more therapies emerge that are able to target the glomerular basement membrane specifically, there may be additional options for him to prevent further injury. The silver lining of this, of course, is that if he does progress and requires kidney transplantation, he is essentially at a zero risk for recurrence. He has, again, a structural issue that should not recur in a transplanted kidney. So how do we counsel the patient? Well, ultimately, ultimately we have a more precise diagnosis, and it helped him understand his whole clinical picture, why he didn't respond to steroids and the ACTH, how his presentation has been, starting at a really young age, and we are able to have a more honest conversation about prognosis. The question that came up is, how do we counsel his family? And again, genetic testing is a tool that we have not had a lot of access to in the past as nephrologists. We haven't really thought about this. We haven't really taken care of patients with genetic diseases outside of CKD, and even that has been, I think, fairly limited. And so this is where I would lean on genetic counselors to help with this step of family counseling.